Okay, you're good to go.
Appreciate you.
See you again. Good luck, baby. Okay, I'll just gimp on out of here, shall we? Thank you.
All right. Well, I mean, and basically, my bona fides or whatever I got, I guess, and how much I'll talk to Helen Wolf. Helen and I spent a lot of happy decades together at Pulaski Community, which is now Lewis Gale Pulaski because they've changed name 10 times. Yeah, and I was ER for about 20 years and ER director for about 7. So, you know, I think she said they still use some of the EKGs and stuff with some of the patients there, but we were just discussing when you came back around. And answering some
They are
questions.
getting new EKGs.
Yeah.
Like I know specifically in Montgomery, Lewis Gale, they're getting new EKGs.
The thing is, the technology moves along so well. Kind of reading the EKG hasn't changed, but the ways to get one. When I first started, I mean, I grew up in Pulaski County, went to high school out here, graduated in '77. So 81 then 85, I graduated from Virginia, the Virginia Med School. But in my rotations, I was at Salem VA. At the time of EKGs there, you had these little, you had to put on this little KY jelly stuff in a suction cup and put the suction cups all 12 places. and it wouldn't stick, but there were no tabs and no quick things. And then the paper would be all this one long strip, and you had to cut it into 12 pieces and glue it in the right positions. So
Wow.
now you have to have it so it goes to the monitor and you record it. And, put alarms if you need to. So yeah, it's good. So, I mean, there's places where I'm sure the technology has been good for the practice of medicine and nursing. Other places that I won't get into where it's been very difficult, but and so that was that's kind of the link there. Although the link that got me in here was the lady that was just here, of course, is Dr. Janet Hanks, and she's in charge of all the academic assistants at the college. And I think when they were talking and seeing what might be needed, that's kind of how that ended. So. The last time I've actually tutored for her in the nursing program, I can't even remember how many years ago it was. I tutored A&P before they had an A&P tutor, and that was a while. But yeah, all is right, because I'll give you all this props.
I did med school anatomy in ODU.
Well, we had med school, we had cell biology. I mean, I had 4 classes probably that did what one A&P class did. That's just not like you want so fast. I don't know how they absorb it all or expect it to. So. They gave me some ideas about what you all might be interested in. The first thing I probably will do is say, what kinds of areas, I mean, they mentioned, pharmacology dosing calculations, they mentioned stroke, and brain injury, and some other things about burning, rehydration. Just tons of things, I guess. Are there things particularly from a tutoring standpoint that would be helpful for you guys?
Mine's just like taking tests and farm, that's literally. Because I know
actual
the
strategy of taking
material,
a test.
I know the material, but when I take the test, it just.
Yeah.
I was thinking more about reiteration of some information that we might have already read or heard about strokes, seizures, brain injuries, different types of brain injuries, tumors, like these kinds of things. Because that's what our test is covering. And burns, is burns going to be on it too?
I don't know where that was. She mentioned
No.
Parkland formula
Yeah,
and burns, but again, there was a lot more than one day worth of things on the list. So.
Burns is one that I know of.
So that would be the next one.
Mobility's the next one.
I was asking about things specifically that you were interested in. Are there certain things that you would like covered either today or sometime in the coming weeks? Or?
At some point, I would like a review of some basic OB stuff that might be on our boards,
okay.
because I don't know if that's, it just seems like it's been so long ago, and every practice test I've taken has had some OB questions, so I'm a little concerned because I feel really rusty on that.
Yeah. Okay.
Farm's a good idea, like if you do have some kind of a technique to remembering pharmacology stuff, that would be cool here too.
Yeah. Well, I mean, the dosing calculations, one of the things I think is so interesting about that is that it reminds me of being back at school where they said, oh, show all your work, and you kind of, really, I can do this in my head, and you can. But one of the problems you've got is if you make the mistake, you don't know when you've made it until you get some really weird number at the end. You're going, that can't be the right number, So, I mean, like I was thinking today, when I was kind of just looking over some things, I was thinking about, I don't know about y'all's pharmacology, but for us, it was always a 70 kilogram man. Do they still use that, the standard? What is a 70 kilogram man? And nobody ever says, I'm hoping to get to 70 kilograms. It's, that's 154 pounds. Why do I know that? Because it's what? how many times the kilogram?
2.2.
2.2, right? And see, that is a conversion factor, and that's really good. That's kind of why I bring it up. That's why the whole pharmacology thing runs up. But there aren't really so many things to know about that once you're setting them up and doing it.
Yeah.
And very simply, if you're writing it out, and you won't always write it out, but do it to make yourself go through the steps, you kind of have to. You know, you've got to know a few conversions, and you know, they'll give you some, like milligrams per kilogram or milliliters, you know, milligram per milliliter on the bottle or something like that. And those would be the things that get plugged into your equation when they ask you the question on the test. You know, so you just kind of get from, okay, I know these things. Here's what they told me in the problem. And of course, in the test, they didn't get sneaky because they'll give you things you don't want to know. Or they'll give you something, you'll have to convert it twice before it gets to something you can use. But, and I guess you know this, I don't know. Let's see, okay, I'm a squirrel. Confession, I'm an old gray squirrel, but I'm a squirrel. So if I go zinging off after nuts and acorns, you can always just kind of bring me back. I won't be upset about that. My own children had to do that for years of helping me with their homework. So anyway, so again, the units. Okay, I mean, I remember my high school chemistry teacher, you know, talking about units, and you're like, why is that important? Well, again, 70 what kilograms, 70 pounds makes a difference. 70 micrograms, 70 grams, 70 kilograms makes a huge difference. You know, so you kind of got to know your units. But the other thing about the units is when you're putting them on just your problem, wherever it is, you know, you've got numerators up top and denominators on the bottom, and you're going to do, well, in fact, wasn't the best pen, was it? You're going to do something with those numbers, and the something you do has to, it's at least something you see, you know, it has to make them cancel out. So, you know, you have a 70 kilogram man, so we'll start with 70 kilogram. And you know, well, if you go 150 or something, but anyway, you start with pounds to get to there, right? So you're 54, and now you just did a conversion because you didn't have any pounds, so you know you have pound and kilogram per pound, and then once you did that, you were left with kilograms, and now you've got something, and you got to figure out, okay, how much am I giving for that? I mean, you're good with the micrograms to the grams, right? It's 1,000. Grams to kilograms, this is 1,000. The volumes are pretty straightforward as well. Of course, milliliters run the same way mils, and I don't think anybody uses micro mils. But you know, the other things are volumes, and these are just things to learn. You can look on the table, but you know, how many milliliters or cc's are in a teaspoon?
5.
5, right? How many teaspoons in a tablespoon?
3.
3, so 15 milliliters. And now you got 2 tablespoons into an ounce, and now you're up to, and those are the only conversions you're much going to use. I guess you can figure it out. Nobody's going to give you a pint of something and say, make this liters. I mean, I guess I could, but it's more of a grocery store thing. So anyway, the whole thing on the units is once you're setting up the problem, you've just got to know that you have these constants, these conversions. And you know, for example, if I was trying to do, you know, how many milligrams per kilogram, you know, you've got top, bottom, and you know, there you are right here, and you want that to cancel out, and it will. The one on top cancels the one on the bottom, you're done with just milligrams up here. You're trying to get down to how many milliliters per hour or something on a drip, but and see this because these things equal each other, this fraction is the same top or bottom. You get that, right? I mean, because that's, you know, you could say 1 because this equals this, you're basically saying this divided by this equals 1. You know, so if you flip it upside down, it's still the same answer. So in this case, if you said a kilogram, so if you need the kilograms the other way around, you can just flip it and make it cancel with the milligrams out or something. I don't know. That's you know, they'll end up giving you, you know, how you have to dilute it to you know, to get it in a drip, or how, if you're just trying to figure out how many, you know, milligrams. I mean, you get this a lot with pediatrics, where you have, you know, this weight of a child, and you have to give them these doses, and then you're dividing it BID or TID. So you just have to go through those and say how many times a day. That's how much I need per dose, and this milligrams per dose, and you go through the weights, and you end up with I have to give them half a teaspoon, whatever. don't know if that's helpful, except to say, do remember that if you're putting the units down, you shouldn't go wrong, because when something's wrong and the number is really way too big or too small, it's probably one of these conversions that didn't happen. And I've always hated this about medical tests too, but there's a little gotcha in all of them, The test writers do the gotcha, your professors do the gotcha. I mean, mine, God knows they did the gotcha. I mean, they loved it, they could just make you squirm in front of people. Ultimately, the objective is for you to pass and do well. The bigger objective is for you to be a good nurse and help people and not hurt them. And, if we were all gonna have confessional time, we all have times where we have done something that made a mistake. And what you want, if you woke me up, I kind of semi-edit this, but you woke me up on a 24-hour ER shift to see a patient. And I came out at 3 a.m. and I was trying to grab a little sleep, trying to make my day work for the rest of the day. And so I can grab some sleep or get some. And I go see the patient and I give you some ridiculous order. You want to be able to say, you can't go, well, the doctor said it, so I'll just give them 1,000 units of insulin. That would be the last order you gave. That would be the last one I gave too. We all, Helen can tell you, but we all, you get to where you work together, particularly when you're ER or a unit or something like that, where you're a team. You may feel like, everybody's just, pushing you around, but really, I'm relying on you guys, you're relying on me. I mean, there's no way I can know everything about people out there the way you all do. And, I might be wrong about something that came up. I might give you a wrong number, and if you check it, then you have to figure out how gently to come back and say, doc, were you still sleeping when you told me that? Did you take a cold shower? Because the number might be wrong. I've seen that happen, actually. I don't remember when I gave a wrong one, but I've had some times where I was so tired, I think I didn't say the right thing sometimes. But I can think of a couple of docs and a couple of nurses I was very close to that were very good, that were told to do things by doctors that had come down to the ER to see somebody that maybe didn't see certain conditions and gave them a number that just made no sense. So if you aren't able to calculate those out, and in particular with the units, then you've got an issue there. So, I'm going to take a pause here in just a second. I'm trying to think if there's anything else specific I'd say about that, but that's really the whole point, is to go back to the units and make sure that they all cancel out. So when you know that you want to come out from milliliters, that you're going to give the patient, or milligrams you're going to give the patient, then you put that here, you put the information you're doing over here, and you figure, okay, how can I get these units to these units? Once you've got them all down there, then you multiply all these guys, divide all these guys into them, and that's going to be your answer. So when you know you've got it set up right, it should divide out pretty quickly. The other thing is, they seldom give you, they're messing with you on these tests, but they seldom give you an answer, two answers that are so close that is the decimal wrong here? Is this 0.1 or 0.2? They might give you one where there's one that's 27 and one that's 27,000, because you maybe need to use the milligram per kilogram conversion or something. But they're not going to just job you. So if you get close to an answer on a test, you're probably at the answer. Now, sometimes
ours are usually fill in the blank.
They are.
Ours are fill in
Our
the blank.
mine's not only fill in the
Oh,
blank.
really, for the test too,
And
you
it's
mean?
gonna be,
Yeah.
NCLEX is gonna be probably fill in the blank too.
Yeah, see, I don't know about that. I was kind of looking at some NCLEX before I came in, because that's what I was like, okay, I've never taken an endocrine exam. I've taken, God knows how many medical exams.
Did you see any multiple choice for math questions?
Well, yes, actually, that was the thing. I mean, there were several of those.
That would be awesome.
There were several of those, and that's what you would
That's
expect
okay.
with a national standardized exam. You would expect them to have that kind of a thing, because they want to know that you can think your way through the process, not fall into the traps. And like I said, they'll give you one answer or two that might be, if you had divided this wrong or put the wrong unit here, you might get this answer. But if you go through it and you've done your due diligence, your answer should look just about like theirs, and you'll know you're okay on that. It won't always be, I'm trying to think what else. What I saw today was, I know what it was, the questions. The first question was, this guy's had a trach, and it drops the pressure 90 to 40. What's the first thing you do? And I love that question. Always read the questions carefully. What's the first thing you do? Because any one of those answers they gave were pretty good answers. But, turning the IV up was the first thing that was on that list. And you didn't have to pull the crash card, you didn't have to call for help, you didn't have to put them in Trendelenburg, you didn't have to, you know, it's all of them have been okay, but there was one best answer, and that's
What'd you
usually.
say, like with the trach?
They had a procedure, and then post-op, they dropped their pressure, was the scenario,
This is a
the
medical
question of
test.
the year.
This is a medical test.
No, it was an NCLEX, it was
Oh,
an
it's
NCLEX
medical?
practice question I came across, but, so I was kind of like, what kind of questions, and the answer is that they're a lot like the ones you'll see on the medical boards. Medical boards, because I just took mine again, 2 years ago maybe, yes it was, have to do them every, if you do your every year medical education, you take them every 10 years while you're family practitioner, ER doctor, either one, so, you know, I just took mine, and they tend to be these huge sonnets of information, and then they start asking you questions on pieces of it, and they're used the same scenario for about 15 or 20 questions. I don't know that yours will be like that, maybe it will be though, I don't know how they do it, but, again, that's the kind of thing for test taking strategies that they'll probably talk to you some about too, but.
There seems something weird, because you start out like an entry level question, and as you get them right, they get harder and harder and harder. And when you miss one, they drop down, and you start getting bonehead questions, and you'll build back up. And what it is they try to, there's like a line, an average line you're supposed to stay right above.
Application, and then just the one below the line is like just knowledge.
Like when I took my LPN boards, when it kicked off at the least amount of questions possible. So I was like, I'm either
Really good.
completely dumb or I did okay, and I had no idea.
Yeah, and that's the frustrating thing a little bit, but I get you there. I don't think they call them bonehead questions.
Well, I mean, it's like hand washing questions, like,
Yeah, no,
like
I
basic,
think
you know.
what they said, how they put it, I think they give you the first 60 or 75 questions, something like that. And if you are exceptionally good, I got this, 95% confidence interval, I know this, or no, this person does not know this, you know, that'll just turn your test off. Then other than that, they'll let you keep on going, and I guess they kind of are trying to get something, because they just have to have the confidence interval that you're in that you're inside the bell curve where you got it, and not that you're.
That's every question I got about like hand washing or fundamentals. I was like, oh no.
Has to be something important.
I want to select all and apply. It means I'm doing well.
Yeah. I don't know, test strategy. I think the other thing is this, and because it gets to have a life of its own when you're concerned about it, but you know, you guys are smart enough to get into the classes. Now, here I have pep talk, but you are. And one of the biggest, and you've had good classes, and you've worked together, and so you got this. And that's the thing, they're not really trying to flunk out a lot of people. There are some people that need to go, but they're on the bottom, and you're not those people. I have a daughter who's a doctor of physical therapy. I have a daughter who's a double master's in psychology and counseling, and they've all had to do these boards and these things. And they're like, oh, I'm like, you know, here's the thing. You're not their target. You're okay. So, I mean, you almost have to keep telling yourself that. Look in the mirror and you go to the bathroom and wash your hands in between. They're just saying, doggone it, I'm good enough. I know this. You know, I would look at the medical questions, even though some of them just ridiculously hard, and I would go, I can't be the dumbest 10%. I mean, you know, that's a real confidence builder, but think about that. You're not in that group. You're gonna be okay. The tester, it has some Mickey Mouse stuff to it, but that's what they're trying to do, is to get that confidence that, yeah, this person knows their stuff. Because if you're at my bedside and I look up and you're about to dose me, I wanna know that you got this. You know, I want to know that you got this. As a matter of fact, I want to know you're taking care of Dr. Hanks, who gave a stupid order and you fixed it, and that's good. Most doctors are not gonna have a problem with that. I think particularly ER and unit are the two places that I would say that you're a family, you're a team.
That's good.
It's gotta be.
That's right out the job.
Is it? Oh, yeah.
The ED and Pulaski.
Oh, nice. Yeah, night shift was even worse. I'm so old right now that nights don't sound good to me at all. But I did 20 years of either straight nights, or 24 was at first when I started, because they weren't that busy. You know. And nights are really like, because respiratory therapists are coming by, they're hanging with you. The lab techs or X-ray techs, they're all there. You're kind of hanging in the ER waiting to disperse places if you need to. So, and you're working, but the night numbers are not as heavy. But yeah, I think that goes for most of the floors. I think med surg is a little different, and that's where, you know, the docs are often monitoring, and they're running off to their office or something, and you're left told all this stuff to do. And of course, all the routine daytime stuff happens on the floors. Labs, X-rays, things have to happen, meals coming and going, and so you're having to juggle all of that. But yeah, I mean, I guess, so that's my pep talk for you with your test, first of all. But the strategies is huge, and the big thing is not to give in to the voices that are telling you you can't do it, because you can do it. And don't unfret you, because you think better when you're a little excited, but you're not over here to, oh my God, you don't want to be on that part of the curve, this excitation curve. So, and when you get out, it's going to be okay, because you've got people to go to, and they're back and forth and checking each other's doses, and that's why they teach everybody ACLS, ATLS. First time I saw that, it was a little threatening, because I'm like, well, all the nurses know they can feel like this a doctor thing. And I thought, no, actually, if everybody knows what's supposed to happen, everybody's ready for the next thing to happen. The one that Helen was talking about, just back on track. The patient she was remembering in particular was this really nice lady, probably at 65, she came into the ER and was talky, and everything was okay. We had some symptoms, dizziness particularly, as I remember, and some other medical conditions that helped me figure out where we needed to go. And then she just coded, just collapsed in the ER. And we had her on the monitor when it happened, so we saw it happen. And so we spent a long time coding her. And there were people going, oh, we're done. We finished the algorithm. We finished all the pathways. And I'm like, no, she was walkie-talkie. She's okay. It's not like we found her on the street. You don't know how long she's been gone. Everything's out of, something's going on here. What we ended up finding out was she had severe hyperkalemia, 10.9, which is way, way high. And we hit her with everything. We gave her everything you can do for that. But when we got the effective potassium level down, her heart rhythm came back. We got her the unit. Next day she woke up, and Friday, that's what Helen was telling me. Friday she went home. That wouldn't happen,
Oh,
But we all knew that.
we looked at this case study.
Oh, it's crazy, isn't
Didn't
it?
we?
That was our lady. That's been a few years back. I don't know where she is now, but.
She was like, that lady got some good care.
Well, there's a lot of people
You have to
give them good
carefully
care.
bring down potassium, right? Or you'll like.
You do, but when it's that high, you gotta really just get it down, and
Insulin.
Exactly, because insulin and glucose have a couple with potassium when they transport in the cell, so that'll bring it down some, and you're adjusting your pH because it's a positive, ion, and therefore, if you pH adjust it, you can get it back in the cells by having more hydrogen hanging right out. It's a number of things like that, but anyway, so that's the kind of thing. But what brought that to mind was the first time I was ever saying, oh, they're going to do ACLS, everybody's going to learn it. And the cardiologist, I thought, wow, gosh, how will I know if I'm good enough? And then I'm like, actually, the answer is we're all working together. Thank God we're all at a certain training level.
Only ER and ICU and stuff do the ACLS.
Pretty much, yeah. That's true. I mean, you should know, but I don't think they require the certification.
Yeah, like med-surg and all that. You don't
They have
to do ACLS.
Usually with some version of emergency response team that they can call for if they need, if something unfortunate crashing.
I mean, like if you do like I do, where I work in long term, like a code is completely different in a nursing home. It's we're just gonna try to get a line and do CPR and call 911 and pray to God that the EMTs get there really quick.
Sure, yeah, and of course
it
they're
sucks,
in the county when you call them, but other than that.
Yeah, I mean, it sucks, but
it's different, but you still are, in that case, like I said, getting a line, activating 911 and giving good quality CPR.
Yeah.
And that's your standard of care for that, and that's great. That's what you're supposed to do. You don't have to be Einstein or whoever.
Sometimes I wish I could just take their bed and push it across the road, because I work at Pulaski. Like if I could just shove their bed across the road, somebody stop traffic. They're taking too long.
I used to joke in the ER particularly that the bank has those little tubes you put your deposit money in. When you get a patient, you go, boom, patient in bed 3, boom, patient in bed 4 from the nursing home. It'd be great. You sit back home, just boom.
It'd be nice.
It would work.
I just hate is like the field that I work in. Like sometimes when I call to give a report to somebody I'm transporting over that's really critical, sometimes I meet almost hostility from ER nurses when I'm giving a report. And it's like, okay, first of all, I'm not gonna call 911 and send you my healthy patients that I can maintain in this facility. I would not waste your time. So of course I'm sending you the 6 of the sick, the one that we've done our checklist of things we can do, and I think it's helping. It's terrible.
Yeah, and I guess it's so hard because again I've been in ER for a long time. I'm family practice now, back where I initially trained, and the hours are not more real. But Yeah, because in the ER, you do have this feeling of, oh my God, they're coming from everywhere. You know, your nurse is
Yeah.
probably really, really, really hammered right now as far as all the stuff she's got to get done or he's got to get done. And, you know, you get this call and you really have to check yourself.
Yeah.
You know, there were some docs I had to talk to when I was director who would greet the rescue squad with some hostility, and that's just, you know, they're doing this, we're on the same team here. So, you know, and if I gotta say, if I'm managing 30, 40, 50 people in a nursing home in the middle of the night, I want them the heck out of my nursing home too.
Mhm.
We don't know, maybe they'll come back, maybe they'll be okay, but you don't know, and you're not, that's above your pay grade to know, I'm gonna keep this patient, make it easy for the ER all night, nobody's gonna give you medal for that.
I mean, I've gotten to where I handle it politely if they start getting rude like that. I'm like, I can send you a few that you don't really need to see. I can waste your time and mine, and you know.
Yeah.
But I'm gonna send you the one go with septic. I'm not gonna send you the one I can get some antibiotics and they're fine, you know.
It's yeah. Yeah, I certainly know what you mean with that, because I had docs that would sometimes do that. I'm like, you just can't. I mean, that's another thing you see in the ER, and then we'll get back to the subject, but, you know, people, the patient will come in, and you have the triage nurse that will say, why did you come in for that? You know, they gave them the message, what made you, and here's the answer, they don't have a medical degree. They don't know if it's
They're
dangerous
talking
or
to a
not.
patient?
Huh?
They're talking to a patient?
All the time.
That's not cool.
They don't do that much now, but you know, you have that feeling like, why do they come in for a sore throat? Do they understand this person's having a stroke? Do they have, you know, no, they don't. In their world, one of the things I learned one of my first days in medical school, we had this lunchtime thing by the family practice guy who's one of my gurus, and he's called Doctor Patient Illness, and he said, to the patient, their illness is the most important thing in the world. Don't forget that. Yeah, they're having a stroke over here, they're having trouble over here, but this patient, to them, what they got going on and how you interact with them is the most important thing in their world. And yeah, it's hard to remember that, because you know, well, you just got a hangnail, and this person's, okay, but their hangnail's important enough, they came to the ER. Whatever the reason they're here. And treat them right, do everything you can for them. You might have to explain to them, they're gonna have to wait a moment for the person you're pushing the medicines for over here, but, you know, that happens a lot in the ER, but they were, you know, it got to where you didn't hear that exact phrase, but you get that vibe, you just can't have it, you know, and it's so hard, because it really is hard. You'll get burned out working in there, it's just so much. And, you know, it worked well for me because of my ADHD. I could do 10 beds at once, because that's how my brains work. But it eventually felt like a lot, because people were coming with stuff when I needed to be thinking about something, like, we need to give Tylenol to the patient with a sprained ankle, I'm like, I got all this over here. So, yeah. So, now, specific areas I know you're thinking, OB probably won't today, although I will certainly look at that, and maybe some reinforcements I could bring in for that if we're talking OB at some point. I mean, I certainly know some nurses and some, I don't know if schedule, but I have a couple of really good friends from OBs that might potentially be interested in coming in.
That would be good. I know that I saw like a lot about the different types of, like the previous.
Oh, yeah, yeah.
There was a lot of questions
The
about
rupture,
that, and then, like how to differentiate with the type of bleeding they have versus where what's going on with the placenta. See, I can't even use the word.
The last delivery I ever had to do as an ER doctor was a full breech.
Wow.
And the doc, it was a situation, I won't tell the hospital, it was a situation where he had to drive from somewhere else and I couldn't get a hold of him. And ER docs weren't supposed to do that, but this patient had already been sent over to the floor, and then, you know, so I went over and I'm reading the monitor, and thank God I remembered some mnemonics I had for what the cells looked like and why, you know. And it was a stupid mnemonic.
Veal chop.
Maybe, mine was Help VC because Viet Cong, and that was mine, and head early, late placenta, variable cord, you know, that's how I remember that. I'm like, oh, it's why they're having depression.
Oh, we gotta
And then I go
see
look
that
at,
on the board, right?
yeah,
So
and then I
we
go
can
look at the
write that
patient,
down.
and I go look at the patient, and there's a butt looking at me when I'm going, oh my God, you know, this baby was backwards for me, so that was, you know, so, but I had to remember, and then I'm doing the delivery, and I'm going, okay, you know, every dirty fellow needs engage, descent, flexion, you know, all these movements in labor, the chapter. I'm like, okay, I gotta get around. And I'm just having to imagine, okay, I'm getting this around the pelvic here. It worked out great, and I thought I did fine. I thought I did really well. I was so pleased. Because, well, the grandmother was our church secretary. And the patient I knew, you know, the mother and the baby. And things went great, and it was a 7 pound 1 ounce boy. I mean, it was a big sized boy. The doc gets there in time to help sew up at the very end. Didn't even have a big tear or anything. I was just, anyway, get through the, so I get there a couple weeks later, the baby's in church, and mom goes, you never done it before, have you? I said, no, deliver babies, I do it all the time. She did the bridge. I said, was it obvious? But that was having to remember those things, because, you know, in the ER, you don't really want to do deliveries. I had a nurse deliver one of the front seat of Volkswagen one time. Okay, so, are there specific, again, thinking areas, I don't know, they mentioned the Parkland burn formula, they mentioned the again, I don't have a whole lot else to say other than here, we could work through some things and maybe it would help, but y'all
I'm fine with that.
seem like you may be, yeah, maybe the people who didn't come today, that's quite possible. Yeah. Intracranial pressure they're talking about, or you comfortable?
Yeah, they're doing stroke, we're doing stroke, seizures, with the endocrine pressure, all that.
Yeah.
Intracranial regulation is what our topic is.
Yeah.
And then, 2:30, we just took a test today, so.
Okay. So.
I know she went over a lot of the different type of seizures.
Mm-hmm.
She specifically mentioned certain medications. She mentioned diazepam,
Yeah,
mannitol, and there was one more she mentioned. Phenobarbital. Which I think with that, we'll probably just have a question about the bleeding of the gums. I think that'll be what it.
Sounds like it.
Like I don't know. I always feel like our
The
questions are
phenazone?
pretty.
Yeah.
Yeah, like that happens. I don't think it's gonna be.
Yeah, so, yeah, okay, yeah, maybe that's a good place to branch off. Okay, so let's talk about brains and intracranial pressure and stuff. First of all, a brain is about like Jello if you left out for a day or two, consistency-wise. When they fix them, I don't know if you had them anatomy, A&P, cadavers or whatever, when they fix them, they're harder. A brain in situ, I mean, in vivo, is just about like day old Jello. I mean, it's really, you can do some damage. That's why car wrecks are so bad and why motorcycle accidents, all these things. So you got now the walls around there are pretty strong, you know, and they're made to be that way. Unfortunately, the inlet coming out is kind of tight, you know, where the brain is finished and you're going to get another spinal cord, the frame in there that it goes out. And then, of course, the spinal cord runs all the way down here and splits off a pair at each level. That's fine. So when you talk about the volume that's inside the skull and the system, you've got about 80% brain, you got about 10% blood that's flowing through, you got about 10% spinal fluid. And you know about the choroid plexus making the spinal fluid, it puts it out there and it pumps through and bathes everything and then it gets absorbed. And that's a circulating system that has to keep going. And having said that, so technically choroid plexus is an answer for why you can have too much spinal fluid and too high pressure, but it's not a great answer because that just doesn't happen very much. You know, if you had to have a whole list of what causes high pressure, that's going to be at the bottom. You're going to tend to see it, with things that expand to take space, and that 80% brain is your best candidate there. So, when do you see it? Well, I mean, obviously it comes on slowly. Something like a brain tumor, could certainly be the source there, because it can swell and it can even, obstruct the flow through the ventricles so that your pressure's going up. Semi-slowly, a subdural hematoma. Grandma, grandpa's, or Hank Houston, now 62, almost 63, falls down. His veins ain't as stretchy as they used to be. The brain is pulled away a little bit from his skull because he's not as young as he was. And just falling and doing that, he may have gotten a tear, and slowly you get some bleeding around the brain. And suddenly there's pressure that's increasing, but that takes a few days to show up. You think, well, he hit his head Tuesday, why is it Saturday he's coming in here? Because it takes about that long for it to be enough to be a pressure. Everything else just the jello shifts around a little bit. Now if Hank had the first worst headache in his life, screamed out in pain and within minutes was comatose. That was bleeding too, but that was a subarachnoid hemorrhage. That was the fast arterial bleeding. Those are trouble in a hurry. They also are harder to save, if you will, but.
It takes 3 hours, you have a 3 hours after.
Yeah. And all these, we'll talk a minute because she mentioned mannitol. I thought, okay, we can go there. But yeah, so those are things that can do it. Obviously, sort of tumor that obstructs the flow can do it. When you're talking about reabsorbing the spinal fluid, what kind of things can slow that down? Well, increased, if you have venous thrombosis, if the venous sinuses are clotted, then you won't absorb so well. If you would have obstruction of the venous return for some reason, it would increase your brain pressure, just the same way that coughing does briefly, except it doesn't go away at the end of the cough. You've got this continued pressure here, so. Those are all things you think about with it. And I guess one of the things that really affects the absorption is things like encephalitis and meningitis. Because, there's two things. I mean, you got, it affects the reabsorption of it, and you've got the barriers are kind of down, so you get some leakage in there as well. Cerebral edema, which can come from several things, that's just swelling up your brains, right? I mean, that's kind of the inflammatory response to an injury. The injury could be hypoxemia, where you've had a code, you've been out for a while, or could be from hypotension or sepsis or shock or any number of things. The point about the intracranial pressure is simply this: you can kind of go with the mean arterial pressure, right? Your average arterial blood pressure is how hard you can push the blood into something. Minus, you basically you're filling. If the gap goes down, then you don't have much window to maintain the circulation in your brain. If you're opening pressure, if you do a spinal tap, or I don't think you'll have to do spinal taps, but the docs don't give them too much, but you do sometimes. If your map is up here and now your intracranial pressure is almost equal to there, you've got really no gradient for the blood to come in, new blood to come to your brain, and you're not going to get enough blood there. So it's kind of important about what's causing that, because if they're hypotensive, low pressure, you're going to have to make sure their blood pressure's up, because the map has to be high enough to give you a gradient. But then you're also trying to reduce the intracranial pressure. And again, it depends a lot on what the mechanism was for it. The mannitol is an osmotic diuretic, basically. Mannitol will hang around when you give it through the bloodstream and will act to draw fluid back out, and it gives you an effect for a little while, and you can redose that. It probably works for maybe up to 24 hours if you're using the redosing on it, It's like a milligram/kilogram originally, but and then you can redose it every 6 hours, 6 to 8 hours. So it doesn't fix the problem. The number one answer, if they ask you this about what to do about intracranial pressure, is fix the problem. The things we just talked about on the list about what causes it, because sometimes you gotta have a surgeon go with a flap and reduce the pressure. If somebody has normal pressure hydrocephalus or pseudotumor cerebri, I don't know if that's a word, but you come across a pair of words, but those are people who have elevated pressure for not a really very good reason, or more, and you have to put a shunt in there, and that's a procedure. You go to surgery and have that done, and that's why a lot of the kids that have, you sit and have shunts, and they'll come in and mom always says have to pump the shunt or do this, but it's not working now, and you got to figure that out. But fixing the problem is the main thing for there, and so you try to make sure the arterial pressure is adequate. The other thing besides mannitol, I don't know if we talked about this or not. Did they talk about hypertonic saline any?
It's in the book.
Is it in the book?
It's not.
Okay.
It's not in the intracranial section.
When somebody has an IV, a bag of normal saline, what percent of saline is that? Do you know? 0.9. Yeah. So there's not a lot of saline. When you're given hypertonic saline, actually, in cases of people who have severe hyponatremia, you're trying to build up, you give them the hot salts, you were about 3%, which is about triple. If they're given hypertonic saline for cerebral edema, and you've got to get it down like now, they may give 7%. And there's some studies that suggest that will work as quickly and maybe as well. Now, I don't know, the long term, I don't think they've got any difference in survival between mannitol and that, but there's the hypertonic saline is also a way that will sometimes bring the pressure down pretty quickly. And thinking about intracranial pressure and what you will have to see up front, one of the things you hear about a lot when you're going through ACLS or something, you're trying to intubate patients, is pre-treating for intubation. Sometimes you just got to throw a tube in there. But if you have somebody who is semi-stable and crashing, or you got you got things you can give them, T-minus 2 minutes, and one of the things that's on that list is lidocaine.
Mhm.
Why would you give lidocaine 100 milligrams? Well, the answer to that question is that there's this real, if you're getting tubed, and that makes your pressure go up in your brain. So you have the same thing as coughing, vomiting, etc. Except in this case, you got this whole body thing. Lidocaine keeps that from happening. So yeah, that might be in your test, because that's one of the things you can do. That's very specialized. You don't do that if they're just coming in with that. But if you're going to tube them, then that's one of the things you may look at doing. Obviously other things to relax them. You're talking about the benzodiazepines, like if you're getting Versed, or one of those things prior to tubing them. Of course, if you give them a paralytic agent to paralyze them.
Yeah.
There was a student in class a year from the UV that did that. They used to experiment on med students for purposes of lectures.
What?
Russ, they had him on a table up the front of a, 200-300 people room. They gave him, at that point it was strychnine or something. They've been succinylcholine, but that may not have been invented at 80-something, 82. And they actually paralyzed him right in front of people. And had one of those students bagging him, because he said later on, he was talking about it, he said, yeah, I think Jen kind of lost interest at one point and stopped bagging. You could tell they couldn't do anything about it, he was paralyzed.
That's bananas.
It's a Jack Nicholson moment, is it not? Stephen King. So yeah, you kind of do that. You say, they don't do that anymore, they would never allow that. But back in about 80, they would have allowed it. But
I don't know, maybe that nurse that just killed somebody doing that, maybe it would make them more aware.
yeah, it's.
I mean, you hate to be negative like that, but
There's
I
a lot of
just
stuff
know
like
that happened,
that.
yeah.
But the case is, but the point is that, so one of the things, if you're giving things in order prior to putting in the patient, you give the relaxant first, you give before you knock them out, because they still can't move, but they know what's going on in there. So, but all of those things talk about endocrine pressure, you kind of look at those. But the bottom line is, get the cause of it down, and sometimes that will require a shunt, sometimes that will require a craniotomy, whatever, you won't be doing that, I won't be doing that, I'm gonna find a surgeon who does that, but, I'm trying to think what else specifically you need to know about that. I mean, other things are just things you would know. Oh, I know what else would be interesting. Ventilation, okay? I don't know if we talked about this, but you got your numbers, you're always talking about how many beats a minute if you're in CPR, how many breaths you give it. If you're bagging, how many times a minute you're doing that. You have ways to minute songs you can sing, but probably not for the test. But depending on the cause of the increased intracranial pressure, you can hyperventilate a patient, because if you're hyperventilating, you're not just giving more oxygen, you're blowing the carbon dioxide off faster. So you're dropping that level, it changes the acid-base balance. It causes a change in the cerebral circulation.
Respiratory outflow.
You're inducing that, and that will give them, that will buy you some time. And matter of fact, there's a question of how much to do that depending on what the source is of their increased intracranial pressure and their CNS difficulty, but because you don't put everybody universally there, but you certainly can buy time that way. And a lot of times you'll hear our doc or a team leader call for hyperventilating the patient for a minute or two. So.
Can you explain how that works though? Like if you're hyperventilating, you're blowing off CO2, how does that affect intracranial pressure?
It actually, the actual levels affect the receptors for the arterioles, and it changes. It changes. I would say that gives you vasoconstriction, because that allows.
No.
Is it backwards on that?
Dilation.
Dilatation. So it basically just gives you some room on that gradient to get blood into the brains.
Oh, okay. All right.
Yeah, you're trying to. You're trying to make sure the brains are getting enough.
Interesting.
So, and that is, again, you will even see ventilator settings for a 24-hour period in the unit like that. They'll have them slightly hyperventilating. Remembering when you do that, you're changing other things too. I mean,
You have the alarms on the
yeah,
ventilators.
which you should, yeah. So they're very complicated these days, but you think about that whole process. I think the thing I probably used to hyperventilation most is all the years talking to people about panic attacks and hyperventilation. But if you've ever intentionally hyperventilated yourself, you will eventually get kind of lightheaded, fogginess. You will get tingling in your mouth. You'll get your hands will tingle. And generally, people who have severe symptoms will not only do that, they will get to where they do that. I I mean, and then you pass out. The beauty of that, and it's just a little too smart ass to say this, that's as smart as I can, right? Just say to somebody who has these spells, oh, it's gonna be okay to take care of itself. Well, it will, as long as you don't fall into trouble, because once you're out, then all these processes go back. But I've had to explain paper bag ventilation to patients for years, and they want to be given something really fancy. You're like, you know what? You're not gonna smother yourself with a paper bag, but you'll get the carbon dioxide bag, it'll fix the acid base balance, it'll fix this calcium flow that you're having, and all these symptoms will go away. And the first couple times you've done that, you'll realize that you can take care of it, and it's just physiology, and it maybe even stop happening. But that's a hyperventilation episode I've talked about a lot, but that's the same kind of thing, acid base balance. And in this case, it's the calcium, the 2+ ion, that you get effectively hypocalcemic, and then so by hyperventilation, you change that, and all the palpitations and the tinglings and the cramping and everything can go back to normal. So.
Have you ever heard of Wim Hof? Wim Hof breathing?
Yeah.
Have you heard of that? Yeah.
I have a friend who does the Wim Hof method, but yes.
That's it, like intentionally respiratory alkalosis. I'm like, right?
Mm-hmm.
Is it not?
This guy also does ice baths every morning, right? You know this guy?
I do, yeah.
Yeah.
It's like, hey, this is bro science, is what this is.
A
It's
little
like,
bit.
it's like this, because, he's hyperventilating himself in order to, like, I guess, hold his breath longer or something like that.
Yeah.
But there's a,
I can have panic attacks on accident. I'm not doing them on purpose.
Yeah, I'm not suggesting you have to, but I mean, the physiology, I'm just kind of talking about how the physiology comes together there.
Boy, that guy, why?
Boy, oh boy.
Well, we talked about clonic seizures, petite mal.
I think
Petite mal is febrile seizures in like mostly kids. Clonic is like the worst one.
Petit-mal are, of course, the French had a lot of neurologists back in the day, and that's why a lot of these words are kind of petit-mal. Petit-mal, who I think that's probably right, considering I'm Appalachian or what I know about French, but it's very much like an absence seizure, like, hey, where'd you go?
Yeah.
You're back down?
Where they staring, when they have a seizure.
And then temporal lobe epilepsy, which always has these characteristic signatures to it, depending on what's going on, like left smacking or pulling hair, and something going on like that.
Oh, yeah.
we should go over that stuff, shouldn't we? Because she was talking about different areas of the brain will have different symptoms during the seizure, or during a stroke, and seizure.
But seizure too. I mean,
Seizure.
actually, you look. It's called a signature. You look for, your left arm always goes numb, or your vision always does this, or depending on what part of the brain is in charge of it.
Occipital, and
Probably,
it's like
when working,
something else, and
Yeah,
there's like
occipital
speech
is
centers
also,
and
is memory.
Yeah.
Right?
Yeah,
Or is
well,
that
yeah. And the temporal lobe tends to dredge up things too, but
temporal is like hearing?
language. There's an area. Right.
No, you're correct.
It's been a
I mean,
while,
that's the thing about the
physiology,
brain that's really cool. Of course, it's really complex how it's wired. They used to, even decades, probably centuries ago, when they were studying things, they came up with the concept of the homunculus, which is a little human that just lays across your head, and you can tell that the body is here. And that's why I always think about how big dogs' ears must be for noses and mouths. It must be a huge area for nose and mouth for a dog that we don't have, because I can't appreciate things like we can, and I don't really want to. But that goes for the other areas of the brain too. So you can certainly look for focal seizure either before, during, or after your seizure, depending. Now, if it's grand mal, what happens a lot is you'll get, and this is not uncommon, you get a signature from the focus of the seizure, wherever it is in that area, and they have that R or that thing that's going to happen. They go, oh my God, and then they get everywhere. It's like a fire catching really quickly. So that's not uncommon to have a seizure focus thing that they found on the EEG or however the neurologists are doing it those days, and it generalizes from there. So, but the general seizure, of course, everything is on fire.
She did say like we got to know what all of the lobes do.
Yeah, that makes sense. Yeah. Now you mentioned that the febrile seizures; those are a little bit different. I mean, the thing about seizures is the concept is a seizure threshold. What does it take for your brain to say, I've had it, I'm going to misfire? In kids, it's much lower. And just a quick change in temperature will do that, which is why they're febrile seizure. You have this sudden change in temperature, and that's why treating them ahead of time is so difficult anyway. parents worry about fevers and how much it's gonna go up or down and how high.
They wake them in the middle of the night, is what they do.
Oh, of course it does. You wake a kid up and you go, well, what we can do now, you woke up that, I gotta go back to sleep. But the problem is usually that first jump that gives you the febrile seizure. And when you come in to the doctor, the nurse, where you are, you'll do a workup for that. But if you don't find anything scary about it, You're most-
When they're older.
yeah, they definitely do go away. But they have about a 1 in 3 chance of having another one within 18 months. Try consulting a parent with that information, But again, within 2 years, usually it's done. And if kids are having febrile seizures by the time they're actually in kindergarten, there's something going on usually, But you look for family history of seizure disorder. If there's a lot of epilepsy in the family, that's it. You look for is there anything else that suggests that you might have had another event that caused that. But your exams, and you got rules on how long it lasts, but it can last for quite a while and still be in the normal range. I want to say to 30 minutes total. I'm trying to remember that. I have to pull the number. I don't put that on the test, but it's a
For
long.
febrile seizures or
A seizure, but for a seizure before it's considered to be. But that goes for febrile seizures too. The kids, usually you're talking about a minute or two. And the thing is, your perception of time is terrible when you're the parent watching your child seize. Very much.
Yeah, I went to the school clinic for a school nurse, and there was one that had tonic-clonic seizures. In elementary school or middle school, one of them.
Mm-hmm.
And they have a separate room, and he wore a helmet because he would just drop.
It's kind of hard to be part of one gang with.
He would have mixture, he would have the tonic-clonic and also the petite mal as well, and he would stare, but then sometimes he would just fall.
Yeah, and in those cases, you've got a lot of things you need to tell people. First of all, swallowing your tongue is one of those earthly myths,
Yes.
So you have people who
Don't
have
put something
severe finger injuries from trying to put their hand in the mouth.
Yeah.
Turn on their side.
That's just doing the side, exactly. Your aspiration, you're trying to prevent. The tongue is not going to go backwards down to the throat in this case. You're not going to stop and put your fingers in there. People don't know that, That's the kind of thing you have to teach them. But
They'll bite their tongue and bite their
And you, if you're that dumb to push it, you can get it out.
well, you think you're supposed to do that because then you think about how much you know that is just urban legend or something you've learned off a TV series or God knows what, YouTube maybe. People know things that they're sure they know, but they're not right. And that's one of them.
Speaking of, I was doing clinical at Pulaski Hospital on Friday, went to the ER, and there was a girl that came in with blood on her mouth, and the EMTs was like, yeah, I don't know where that blood on her mouth is from, and the nurse immediately said, open your mouth, and the girl opened her mouth, and you could tell that she had a seizure.
Mm-hmm. Mm-hmm.
And it's weird that the EMTs didn't pick that up.
Yeah,
It was
you
just
wonder if
off
they
her
were just going to do a
mouth.
checklist or something and didn't think about it, but you would think that'd be a pretty short investigation.
Yeah, 'cause she was unconscious in her yard. Why would,
You get that a lot too when people come in with vomited up blood. They had a huge nosebleed just not long before that. You're like, yeah, you did. But if you swallowed it first. But so types of seizures, OB you were talking about, I'm getting. Yes, 201.
I'd asked Wendy, I had a home health patient with infantile spasms, and my patient had a weird presentation that wasn't easily identifiable. She said she was gonna try to maybe talk to us about recognizing seizures in infants, because sometimes it's not as pronounced as an adult. It's, like the little dude I work with, he just started drawing up his knees randomly, and I thought it looked like he had gas, and he just kind of, because
Yeah.
I have kids, and when they have gas, they pull their little knees up, and that's what they do.
Babies watch individual molecules of air go by, so how do you know if they're looking at me?
Yeah, babies are weird.
Yeah, well, I'm not sure. A lot of that is we'll tie back into the neurology, the neuroanatomy, all we're talking about. And I think that's what they're saying as far as kind of having an idea about what parts of the brain are involved, because identification of seizure focus has a lot to do with signature, and it has a lot to do with where can you identify a part of the brain that should give you those symptoms you just had.
like balance
I'd like-
problems,
I'd like to do that.
hearing
just-
problems.
She brought it up, she said she can't even actually find a map herself
She
of the
mentions
brain,
Oh,
you know.
there's-
She mentioned
stuff on
specifically
there.
the cerebellum, she mentioned specifically the
No,
pons.
I can find it.
Oh.
I don't know which one she wants. Like she says that she keeps
And
looking
the
at like these different areas.
dicephalon, am I saying that right?
Different areas of
She
the
mentioned
brain.
those three brain
I pulled up
areas,
the
I think that's
anatomy book
testing
to just like
the
look at her
areas
old
she's gonna
anatomy book,
focus
you
on.
know?
Oh, I was just looking it up and what the different.
It's,
books
I took
were.
anatomy way too long ago,
She said she
sometimes
couldn't
it's
find what she
so
wanted. So, you know,
And the problem is you take it that far back and all you're gonna sit in the classroom, it is so hard. And in your training for nursing, if I'm a physician, you got a certain basic you just gotta do.
Yeah.
But what really can happen is when you can say, oh, that little kid was drawing his knees up, now I can make it make sense. Or the patient, the one from the nursing home, or you can kind of go back and make sense of it by because that mnemonic book of real people is pretty good. And then it makes more sense when you go back and look at it, which is what you'll find yourself doing a lot. I mean, I used to have a book, my wife used to joke, I've known her since high school, by the way, we've been together a long time, but I used to have a little black book before there were all these things going around with you in computing. It was called, she used to call my ectopic brain, ectopic meaning outside of, and I had everything in the brain. And I got to where I had 2 pockets of brains and I pull them out in the middle of the night and looking at them and stuff. But, a big hunk of what you gotta do is know what you need to know quick, know what's normal and spot abnormal, and then know where to get help.
Yeah.
Whether it's a person or a program or whatever. Yeah. I mean, it's 2:03 now, so I don't know if there's specific other things or if there are things you'd like me to come back in with next week or specifically, because again, I was just kind of going on some things they thought you might be interested in, and I'm happy to go any direction we want to go or you need to go. And hopefully we can make it, so I asked about practice questions and such, and I mean, we can probably get some if you want some. I don't know about the exams, but.
I'd rather, practice questions are good.
yeah, they are. I'm looking for wherever Burns was. Did we do it a long time ago and I just forgot about it?
Oh, another thing, I think
I
she'll
don't
probably
think
have
so.
some of the Glasgow coma scales, so it might be good to have
Oh,
like some
yeah.
descriptions
Oh,
of
yeah,
patients
some
and then have
questions
to
on
come
that.
up with a number, just to practice on that, because you get so used to like, well, even when we do clinicals and we chart, we enter in all the data, and then it tells us the score, like it'll say how they open their eyes, and like you get to where it's just habitual and you don't really even think about the number and how you're getting to it, it just kind of pops up.
Yeah, in the stroke scale, you've just done stroke, and that's huge. I mean, I guess, I was in a couple ERs when they put through the big emphasis on the national stroke. And of course, the thing about having a quick identification of stroke is simply this: if you know it and they're a candidate, you treat it. And so anything else that slows you down that pathway is a problem. And so they got to standardize it. So stroke alert, what are they doing? Well, they're calling the CT to be ready. You have to have a CT scan open and ready.
That's the first thing.
Yeah, and what do you need to know before you go to the CT scan? Well, not a whole lot, really. You need, you set vitals.
Just look at them, like.
Yeah, pretty much.
until-
You want the sugar. You do need the
Yeah,
one
that-
lab test. You use
she
the
did
sugar.
say that.
That's what you need.
Mhm.
Because hypoglycemia can do all sorts of weird stuff, and you got to make sure it's okay, and that's not the cause of everything. You know, TSAT. You kind of want the oxygen sat. You need to know the blood pressure, but you don't. That's it before they go down to the scanner. Now, usually your stroke team will come in and they'll be ready at the bedside. You'll draw bloods real quick, and so if you can steal a minute or two before they go down there, that makes sense. And then they're running off lab because that takes longer to get it back. But there's nothing else in that lab you have to have before you do your stroke.
Yeah.
The thing that brought that to mind, though, is your National Institute Stroke Scale, right? There are possible 42 points on that, There are so many things on that. And we use it, and you'll do it at 1, and you do it at 5, and you'll do it, you do it various times to be able to judge where they're coming or going, because that's important for the prognosis. But having said that, you could say, yeah, this is the stroke scale, these are the big numbers we're using. But if you are doing facial, and speech, you pretty much have a very good idea what their stroke situation is. Those 3 components, which are part of the bigger one. But doing the stroke scale, you get very good at that. But again, like you were talking about filling in, you've got the sheet, they print out your sheet or whatever, you just do, and it says, oh, they got a 25 there, it's bad. So, yeah, so I mean, I think that the GCS is, you can get that a lot. Of course, the rescue will want that too. Again, big indicator in how urgent is this. And you get, as you get into your nursing practice more, you get more and more comfortable with that. You'll see enough. You'll be able to look at people and know how sick they are without having the numbers as much. But if you're talking to somebody else about it, just saying, well, he looked really bad, it's not gonna cut it, but if his scale was this and his score was that and his number was this, you guys can all talk to each other about, and you can say, well, 5 minutes ago, she said that these numbers were here, and now they're here, we got a problem. Or, hey, no, maybe we said better, they may be just waking up from a seizure, they weren't having a stroke after all, they had a seizure, we didn't know it, they're waking up. So GCS and practical.
And yeah, she talked about using TPA with stroke.
Yeah, in place beyond. Yeah, again, it's so funny on that, because again, that was not something that was done, I think how far back, 15 years for sure. I was in the ER, there wasn't much you could do. And the weird thing was, working locally as this, we did have a lot to offer a lot of people. It really was only when the TPA became more widely available and you had protocols for using it and they began to be able to show studies where it was better to give it than not give it, that there became such a push to standardize protocols. Because here's the thing about TPA, your chances of hurting them versus your chances of helping them, I mean, or help to hurt is about 2.5 to 1. You could make people bleed with the TPA. Of course you can. I mean, that's what it does. You can do all these bad. You could enlarge a stroke, make a non-hemorrhagic into a hemorrhagic stroke. You could. So you got to have somewhere to stand on that. And you got to know why you're giving it. If they meet the criteria, you do it. If they had a GI bleed 2 weeks ago, you can't give it. If they've had a stroke in the last 3 months, you can't give it. Hemorrhagic or non-hemorrhagic, you can't do it because the risk is suddenly not okay compared to the benefit.
So even in this emergency situation, you have to know these details about their history.
There are
their
things you
recent history.
really do have to know. And then,
Like, not just CT, whether or not it's
Right,
bleeding,
right.
you've gotta know some recent history at least.
The CT gives you a quick one. The other thing too, I mean, I guess you have to have time once they come through the door.
Yeah.
If the last known well time, if you cannot identify when that was, you're kind of out.
Yeah, you have within 3 hours, she said.
4.5 is the top end. 3 hours of what she says, that's what you go with. 4.5 is the top end.
She said 3 to about 4.5.
Well, she said that the insert on the box of 4, like, I think that's what she said.
It does, yeah, and it's ages too, because I mean, if you're a 50-year-old's doing this, it's different than if you're 80-year-old's doing this. 80-year-old's got much bigger risk for getting it, and so the highest one I've ever given to was 95.
Wow.
Patient over
TPA?
in another hospital, called up thinking I was just doing due diligence to the neurologist. This is another hospital, so I called Baptist, we're in Wake Forest, and they give it, I'm going, meeting contraindications, but this stuff is 95, but, actually it was funny because that same week I had that one, I had an 85-year-old guy who was riding on his golf cart on his farm and checked on his cattle and had a stroke. They both got TPA, they both ended up with Baptist, they both made full recoveries. Doesn't always happen that way. But what I do remember that the lady was, the 95-year-old was, I got this message, it was the Labor Day weekend, I got this message next shift I worked. They said, Dr. Blank wants to talk to you. I'm like, oh, snap, he's mad at me for sending him a patient who was 95 and doing all this TPA and everything. And got on the phone, he's like, I just thought you should know how well Mrs. Jones did. I don't know what he really was, but, and he said, I went into the day room this morning and she was, physical therapy had her playing balloon volleyball with another patient and she was winning. And I'm kind of going, what? So, yeah. Anyway, so the story on TPA, but yeah, so yeah, give the TPA, and they will have packets for that.
Yeah.
You'll have the contraindications, there's absolutely relative contraindications. You know for the test, but they're gonna have them right in front of you, you have to check them off. Because the risk is just so high that if you give it and you haven't checked for those things, it's trouble. Yeah, conversely, the success is enough that if you don't give it and you could have, would have, should have, that's big trouble too. Because again, I was on the front lines when this stuff came out. We were at the ER guys were like, oh, I don't like this because I'm going to give this a make a bleed. Now it's going to be my fault,
Mm-hmm.
But then in big metropolitan areas, particularly one case was up near DC. There was a huge suit for somebody whose mom or daddy they thought should have had it, and there was some scientist, doctor type person whose parent and everything the suit was settled in their favor because hey, you had a possibly life-altering treatment and you didn't give it.
So how does that work? I mean, this is kind of like off down a rabbit hole a little bit, but like, for me, example, I have rheumatoid and I used to take Celebrex all the time. That's just what I was given until I went to the ER throwing up blood.
Mhm.
So to me, like, what if somebody, even if they're not known to have a bleed, but it's known chronic NSAID use, how would that?
That's not an absolute contraindication for it.
Okay.
Yeah. Matter of fact, neither is giving aspirin. We give aspirin up front, you know.
Okay.
If they had active bleeding, it would be. It
Okay.
would be. But if they didn't have active bleeding, and if you're not sure, you put a finger in the backside and do a pulse. Just check it. But yeah, it would not be an absolute contraindication.
Okay.
If you met the criteria for it, above 18 years old, pretty much, you know, it's just the whole, there's the argument of pregnancy and such. I had one lady that was pregnant who were worried about giving it, and talking to the neurologist, he's like, you know, I think this is actually a complex migraine that has a neurologic syndrome. Thank God it was, because otherwise we would have a pregnant lady, we were about to give this massive blood sugar to maybe, and, you know, and I was not completely comfortable with that, but he was the neurologist. I wasn't comfortable giving it either, so, you know, a lot of times in practice, you're not comfortable with either solution. They all seem bad, but, oh me. What do you think, guys? Is that gonna be the kind of thing we should do again? I mean, is there things, if there's specifics you want, and if you give Wendy or Helen, they can get a hold of me. I
Okay.
mean, you know, believe me, Jan Hanks is right over here in Markham 212, so they know how to get a hold of her, and they got my email and phone, so, anything I can do to help. I mean, I haven't taken a single nursing board in my life, so taken a lot of other tests.
I'm not looking forward to it. The first one was bad enough. I was glad I passed it the first time, didn't have to go through it again, or so I thought.